And we need to understand if we're providing care fairly and addressing sort of health inequalities, which are the unfair and avoidable differences across healthcare, of healthcare across the population between different groups within society. And I'm not going to read everything on there. You can read that yourself. But when we start looking at the data, that's when the healthcare and the deprivational information starts showing things in our society that we perhaps need to address. If I look at this chart here, it tells me that people with learning disabilities die on average age 63, which is around 20 years lower than the general population. Homeless men and women die a lot younger than the general population at 45 or 43 years. This article was published by the King's Fund, so the link is there that you can follow to read up more on it. But the deciles in these two charts for the men and for the women. So the decile 1 is the most deprived areas, 10 being the least deprived areas, and the state of health. So if you're in good health, you are more likely to reach your pensionable age in a least deprived, if you've been raised in a least deprived area, than if you have in a more deprived background. So as a trust, we look at that information in our own sort of areas. So this is 2 areas in Humber that are actually 5 miles apart. And when you look at the levels of poverty between one area, sort of 44.8% of children are in poverty versus 3.8% in the less deprived area, in the more affluent of areas. And you can start seeing that how do we tell that we're addressing or delivering care in these different areas fairly? So with costing, I'm not going to go read all of the bits on here. It's very interesting, but I'll let you read them in your own time. But when you take the costing information for those 2 areas, so this repeats, it tells me how many patients we have in each of those deciles. So Team A has the most deprived areas, Team B the least deprived areas. When I add the cost information to that, it seems to follow the same sort of profile. But if we are delivering care fairly, this bottom set of charts, the bars should actually be fairly flat. We should be spending roughly the same per patient in each of the deciles. And for Team B, I can see that we are spending a lot more money in deciles 3 and 4 than we are with patients in deciles 1 and 2. So as a trust, we need to understand why that's happening. Is there a barrier to entry that's stopping us delivering care to the patients that need it most? Where do we can start looking at where we deliver those services. Are we offering appointments at times that won't clash with times when they have to work? Are we going to see the patients? Are we making them go somewhere that they're feeling uncomfortable? We just need to, it raises questions looking at the costing data that we need to investigate and sort of address. So I believe you can cost anything with the right information, but that data does not need to be perfect. But the better the data, obviously, the more reliable the outputs are from your costing systems. And the more that we review that data, the better the informational outputs come over time. So as long as I review this information with my services and make sure that we're costing in the right way, it's a real good thing. Difficulties in costing a mental health provider. We've had issues in the past around the accurate recording of data. We've never had a national payment by results tariff and little to no clinical coders. The people that record the information are our clinical staff. They record what they're doing, which obviously takes time. The grouping or categorization of what we cost is very difficult in mental health. It's not been broken down like the acutes have into lots and lots of health resource groups. So it's harder to make comparisons. We may have a team delivering care in the community to a number of mental health patients, but they may have all different types of illnesses and needs. But there are new mental health and neurodevelopment resource groups that are being developed. This launched initially in 2024, but it's still changing. And I'm not going to go into the slide too much, but everything outlined in red is a change to the currency, mental health currencies to the prior year. So things are expanding and getting more detailed. And so we have to change the way we cost to collect the new information to support filling in the cost submissions in this format and start to understand more detail about the patients that we deliver care for. And the final difficulty in costing in mental health is pretty much measuring the cost, measuring the outcomes. Have we made a difference? Have we made a difference to that patient and their families? And as I say, we're starting to collect more information on the problems, the patient-reported outcome measures, the clinical recorded outcome measures, but as yet I've not pulled that sort of information into my costing system, but it's stuff that we're working on to do going forward. So PLIX, the patient level information costing system, joins together the healthcare activity with the financial information. It provides us with detailed information about how the resources, like our staff, are used. And it helps us to focus on target areas that are either in need of improvement, but the one that I think we forget to do at times is to showcase areas that are doing well. And it's a key that we allocate costs to our patients in a meaningful way, and so that we're consistent and fair and comparable. So we do have national guidance that tells us how to allocate things like our estates costs, where we use the metres squared and the room usage and the time usage. We'll allocate things like HR and payroll costs using the actual whole time equivalents or headcounts. Our IT system costs are allocated to the users that are licensed to use that particular IT system. Insurance costs are allocated to based on a particular insurance schedule. So, and there's different methodologies. So the approved costing guidance, and in particular the technical specification document, has a list of those if you want to have a look in your own sort of time. But for mental health trusts, 80% of our cost is pay, and there are a couple of ways that you can allocate pay to patients. One is a single stage method, and it takes the total pay cost for a staff member and allocates it to all of their activities. And I'm not actually a fan of this method, because in a mental health trust we often have one staff member that can be a particular grade going out to see a patient, and that is completely different to a different staff member on a lower grade going out to see a patient. And there is a big disadvantage with this method if there's low activity. So if a staff member goes out and sees one patient, and so say has 30 grand of pay costs, but then goes on sick, I don't want to allocate that 30 grand of pay costs just to that one patient activity. So it overinflates the pay costs if you use that method in a mental health. It might be more suitable if you've got, say, a theatre in acute where you have an anaesthetist and a surgeon and some nurses in there, and it's a similar setup every time. But when you're going out in the community, one staff member at a time, it doesn't really work for us. So we use a two-stage method that initially allocates a cost per minute for every staff member to the time that they have recorded in our electronic patient record, against the minutes that they've spent with each of the patients. So staff members' pay rate per minute times the minutes they've spent for the patient, and we build up a level of cost for each of the contacts and activities, whether it's a supporting activity to those patients. And then so it builds up. It doesn't allocate a full level of staff members' time because nobody records the 37.5 hours of their working week against patients in a mental health trust. So that whatever's left of that pay cost that we haven't allocated directly by the minutes they're recorded, we allocate across the team's activities, almost like overhead to the team. So the benefits include a fair reflection of the cost of pay to patients when there's staff sickness or low recording, and it allows us to monitor and compare staff resource usage, how much time they're spending with and doing work for patients. So staff A and staff B, one records 51% of their time, the other one records 75% of the time. If they're meant to be doing the same job, you need to understand why there's a difference. if they are completely different bands, that might be fairly reflective, and you might be happy with that. The managers will sort of know that. There is a slight disadvantage to your costing system. It takes a bit more time to build, because we build this not only for our employed staff, but or any of our agency staff too. So it can take us a little while to collate the data, and it's the more detailed your costing system is, the slower it can become. So this is a few patients. Sorry, I've just blanked out names, and we can look at the differences between what they've recorded. So the top top staff member R has recorded 77% of their time. Staff member A at the bottom has only recorded 28% of their time against patients. That 28% might be brilliant if they are one of the managers of the teams, and they tend to do a lot less patient-facing sort of time and do a lot more, I don't know, clinical safety work or something like that. So it just allows us, from the most granular level, to understand how much time we spend within the trust doing patient work. And obviously this is something that we want to improve, because spending more time with patients is what we are here for. So the data can be aggregated and reviewed in a variety of ways by roles, bands, teams, and it does highlight splits. We can split it, so I could see these percentages of how much time they've actually spent as patient facing and how much time they've had to do supporting activities, and we can then bring in different things to try and improve the time we spend doing supporting rather than patient facing. So we actually want to increase the time for patient care. This is another bit of data that I can pull out of our costing system. So this is just some some did not attend information. So we've got a number of contact activities that should have been the contacts, but the patient didn't attend. Where I've highlighted in yellow, I wouldn't actually expect there still to be a 61, say, minute duration for the 74 contacts, or an average duration of 74 contacts. If the patient doesn't arrive, I'd expect staff really to find something else to do and not lose an hour of time. The bottom chart here looks at the split between the time that people have spent travelling to the time that they've spent recording contacts. And if staff member D at the bottom only spends 8.9% of their time travelling to patients, but staff member M in the middle records 31% of their time, we need to understand why, and can we plan M's routes better, and when their appointments are with particular patients to be in certain localities, so we can use that information. So from a productivity perspective, we've certainly set up groups internally to try and improve our own trust productivity, because we felt that when we were compared in things like national cost collection, that we were an outlier. We showed it expensive, but we felt that we weren't really reflecting what we were doing. So we've spent a lot of time looking at improving our productivity. And so obviously, if you improve your productivity, the aim is to get shorter waits. If you get shorter waits, we should get a reduced risk in the backlog of our patients, so that we should treat them, if we treat them earlier, they're not going to get worse, or shouldn't get worse while they wait. There's a better continuity of care for the patients and better patient outcomes ultimately. So from an NCC sort of productivity, we as a trust, we focused on looking at our national cost collection targets, and looked at the services that were underperforming. And then we did sort of productivity deep dives on those and tried to investigate what was happening within those services, what was causing the issues. Was it sickness? Was it vacancy rates? Did we have high agency spend? What were the waiting lists for those services? Did we have a problem with DNAs? And so we did sort of capacity and demand work. We spent a bit of time training as well, staff, we reviewed all sort of the clinical notes, and how the guidance told staff to record in our systems. So training ironed out quite a few of the inconsistencies we had in guidance and EPR setups and things like that. System development and ensuring our data was there. So we've had digital enablers come through. So we use things like voice recognition software to free up time from recording notes, clinical notes. We have systems that allow us to send out text messages to patients to remind them of when appointments are, or they can send out questionnaires so we can get feedback in the format that we need. There's certainly lots of different tech that we can use to speed up the time that we do certain activities. And the service delivery, we looked at the way that we delivered care in those services, and was the process changes that we needed to make things more efficient. Should we have one single point of access, or stop repeating assessing in certain areas, so things were done once and not multiple times. So these are all just the different enablers that we've been looking at. I'm not going to go into any particular detail of them, apart from probably the last one. The shared care record is something that we've been heavily involved in. And so now our clinicians can access not just the mental health information of the patients, but they can review the stuff that's in the queues or in different trusts as well, to speed up and make a better understanding of what is actually happening with that patient, and how it affects their patient care. When we cost, the data comes out at a very granular level, and you can aggregate it back into different ways. This is a pictorial way of a particular patient's journey through a particular year. This patient actually cost us £132 to treat in year. They saw our GPs, they saw our community mental health teams, physios, crisis, psychology teams, and required an inpatient stay as well, which was quite a chunk of cost for us. You can slice and dice that data in a different way, so we can look at it in when the contacts and activities happened, when they had bed stays. We can slice and dice that into the costs that feed it from the ledger, so we can see how much we've spent on nursing or overheads, how much estates cost we've had for using particular buildings. You can change the way that you do things, and you can slice and use the data to compare teams. So at the minute, I've got on the slide here different teams. Team 1 has their highest average cost per contact in here, but it has the second lowest average cost per patient. So are we spending a little bit more time delivering that care with maybe a higher banded staff to that patient, and getting a better but shorter overall length of stay with that patient than other teams? What can we learn from it? Team 1 attracts the highest level of overhead, but team 4 the lowest. Is this caused, if people review this, we can see whether it's caused by and maybe even an error in what we've done in costing, or is it caused by the base that they're operating from? Should we look at where we're delivering services from? Are some of our buildings past the point of no return for repair, and we maybe should look at better options of consolidating some sites together? It's just questions that we can start answering by looking at the information. Costing information is definitely not perfect, but the more it's reviewed and shared, the better it becomes. And it's improved our data entry it's improved our guidance and training. It's improved the level of DNAs and frequency of DNAs that we have. And we've reviewed the level of care that we've given to some patients that we realised we actually did quite a lot of activity with, were probably in the wrong service, and we've moved them to something that would be more suitable for a more complicated patient. And we've spent a lot of time reviewing how we look at capacity and demand and productivity. And so we work together to try and review and improve targets. So it enables you to see comparisons. So the improvement in patient care enables you to see comparisons, variation, highlights potential areas of concern and good practice. And we can review the patient journey for planning purposes. If I see a cost of a patient and a profile of a patient, if we say have a national campaign for dementia assessments and suddenly get lots of referrals for dementia assessments, we can review the resource that we need to be able to meet that demand, and to have a discussion with our commissioners to meet and get through a blip that we perhaps didn't expect with the extra demand caused by national campaigns. And obviously the data can be used for our ICBs as well to help them plan how they spend. So the big one as well is you can use that information to work with others. If we want to look at as a patch what we're spending, I don't know, on mental health patients within an A&E attenders, frequent flyers, that sort of thing, we can work with our acute peers to try and provide the mental health support in a different environment, in the acute environment, in the A&E, to try and stop patients with mental health issues turning up at A&E without almost a physical health problem. So any questions?
Just wait a minute and see if any questions come through. Oh, there's one come up on the chat. Are you able to see the chat, Claire? Do you want me to read it out?
I can see it now. No, because it doesn't push back from the staff, because it's not about saying you've been naughty, you've not recorded your activity. It's about understanding where we've got issues, because if you've not recorded in the patient record that you've been to see a patient and what you've done and treated that patient for, your defensible documentation, and that is not completely there. If we can see that somebody's spending too much time I don't know, writing up clinical notes, we can try and find a solution to aid them to improve, because ultimately staff want to improve as well, and they want to make our services deliver care better for patients. I don't know whether that helps.
I think we'll just take the question from Melanie, who's got her hand up, and then we will need to move on to the next speaker, if that's okay, Claire.
Yeah.
Melanie, what was your question?
Thank you very much, Claire. That was very, very insightful, and I'm looking forward to the slides. Two questions very briefly. One is, how do you determine the target level of productivity expected from your teams? And B, who decides what activity is recorded, for example, travel time or time spent writing notes, for example?
That's the target level. I know on that chart it had an 80% for those particular things. It was just, that was something that we made up at the time. The services actually define by role what they really would be expecting their staff to be doing clinically. So how many contacts they'd expect roughly over a month for delivering care, and how long that sort of appointments is. And it varies obviously between bands and roles between people. But it's not something that we use as a stick. It's just to use it as a guide to try and, as a trust, figure out where we are spending time and trying to improve the time that we spend with patients, because that's the bit that makes them get better. I suppose, what was the second question? Sorry.
It was, who decides what activity is recorded? So, for example, travel time or writing up clinical notes included in the kind of activity reporting?
That's been something as a trust that we've just recorded for a long time. It's not something that has recently changed, because obviously if you've got two patients and you spend an hour contact with the same staff member, spent an hour contact with each, it's a lot more expensive to treat the one that you've spent more time traveling to, or had to do more supporting activities to. Staff really wanted to try and reflect the cost of the true cost of delivering care, and if we only costed the actual physical contact, it didn't make any difference between what was being delivered. particularly in sort of children's services where you do spend a lot of time educating and working with schools to help promote mental health awareness and work with students and children and young people's families. But
No, I appreciate that. And is that something that's who decides that within the trust? Who makes the decision about this is the activity we want to capture and this is our sort of reflection of productivity?
Well, I suppose that would come ultimately through the performance and productivity group, which is chaired by I'm just trying to think of a job title. I'm just going to have to look it up to tell you. She's the Deputy Chief Operating Officer.
Perfect. Thank you. I know who I'm going to chase in my trust. Thank you very much, Claire.
Okay.
Thanks so much, Claire. Thanks for taking the time out to present for us today. Sorry to cut you off questions.
No,
but are you happy if any others come through? I'll pass them on to you if that's okay.
Yeah, no, that's fine. Thank you.
Fab. Thanks. Have a great afternoon. So next we're joined by Rich Sawyer. Rich, I believe I saw you on the call.
Oh, yeah.
Richard. Hello. Your job title's changed since I last spoke to you, so I'm going to let you introduce yourself. Over to you, Rich.
Yeah, it's a surprise to me as well. Hello, everyone. I'm going to try to get back some time for us on this item. But so my name is Richard Sawyer. I worked for the last 5 years as in the Finance Innovation Forum as part of One NHS Finance. But last week, I'm now working at the Deputy CFO's office as Head of Innovation and AI. So I'm going to run through a framework that's very close to my heart and something that we've been developing for quite a while at One NHS Finance. Evo, it comes as a free project management handbook for your finance and project teams to deliver in an MDT clinical setting on 3 specialties over a period of 20 weeks. I'll talk to the title slide. I'm not just sharing pictures of childhood avatars for fun. These are all various different AIs that I've built in the last couple of years. This one on the top right is the Evo AI, and essentially you don't have to read through 189 Agile framework documents to understand the framework. Any trust that applies to do Evo can get access to the AI, and it knows as much as me in terms of the framework itself. So I'm going to take you very quickly through the framework in about 10 minutes. And if there's any further questions or otherwise, please give us a shout. So ultimately, this is about implementing a lot of the things that you've heard about in terms of the data set that's available in Plix, but also the value-based healthcare. So and bringing this as a practical, measurable tool from quality and clinical quality and resources assessment into a practical quantitative measure. So I just need to define the value equation for you. So it's defined in many different ways and is generally considered a theory of measurement rather than a practical one. So we're trying to bring this to practical teams on the ground and have been doing so for a number of years. So value for the purposes of the framework is defined as outcomes or quality relative to the costs or resources. That is to say, basically, that it's widely acknowledged that focusing solely on cost cutting without maintaining and enhancing the quality of care can lead to false savings and harm the delivery of effective care. So we cannot, as healthcare providers, continue to make decisions about quality and cost separately. And this framework brings them together under the banner of value-based healthcare to balance both of those interests in an MDT setting over a period of 20 weeks. Teams will work together over a timeline, starting out with forming clinical hypotheses or clinical hunches that you and your colleagues would come up with in the first session. Then the teams will go away and find the Plix evidence relating only to those 3 hypotheses. You'll come back and validate as a team in the second session. Then you'll use measures to understand and prioritize the changes that are most appropriate for transformation across 3 specialties. And I'll go into a bit more detail in that in a minute. So after you've done that, you'll then implement those changes to your specialties. And after sort of 4 or 6 weeks where you've had a chance clinically to understand what those changes meant on your within your service, but also collecting the data and PLIX information as well around the activity and resources consumed with that change, you'll meet up and you'll have an impact assessment. And that ultimately, that process will produce the value impact comparison score, which is factored for clinical outcomes, patient experience, but also revenue, costs, strategy, and risk. And this is a percentage improvement score that comes out of the process. Very useful to have a quantitative metric of improvement, which balances both quality and resource elements appropriately. Okay, so as I've said, it's run entirely by your teams. So I can go into who they are. It's built to be very clinically light. So in terms of attendance or commitment to the framework, generally your finance and your project folk would collaborate to do a lot of the work around your clinical requirements. So you would attend a session for 2 hours once a month for 3 months. Okay. That would last for a 20-week period. And you'd also start working as a close MDT to understand how data can evidence your clinical hunches and decisions, and then move through to material change through satisfying EQIA requirements, business cases, resource optimization, these sorts of elements as part of the framework, and delivering instrumental change, and then measuring the impact of that change based on value measures that you set. And I'll come to the tools in a minute. There's about 150 resources in this framework, all freely downloadable. It's templates. There's a lot of QSERT in there. Those of you that are aware of quality of service improvement redesign resources, there's Lean Six Sigma elements in here as well. So this framework isn't just another thing added on. It was essentially created to embrace and wrap around all of the ongoing initiatives in the quality space, whilst factoring in and bringing in the evidence needed. Who take part? It requires an application because we need the board to protect the time for you to do this type of work. We found in the pilots that a lot of the work generally falls over when you haven't got board or direct exec level sponsorship of the program. So your finance champion, your clinical champion, your transformation director would all need to be signing on the dotted line across the timeline of that 20 weeks to protect time for you to do this work. And they're the champions. Then you've got the leads, the core teams. You've got the finance lead, costing folk. You've got 3 clinical leads because, by the way, we run 3 specialties at once in that 20 weeks. So after that 20-week period, you'll have 3 different services. All have completed what we call the Evo orbit. And then we've got a delivery lead, which is project manager, and then you have a facilitator. Okay. And you work together as a core team of around 7 in a very lean outfit to make decisions on these opportunities that you've identified as a clinician, supported by the evidence, of course. You can include the specialty nurse, finance business partner, and informatics as well. This is the 20-week journey. I won't go through it in too much detail, but you've got the 2 blue sessions there, which is essentially your kickoff of the project with everyone, all 3 specialties attending, and then the landing, which is your show and tell of what you achieved during that period. The red, the yellow, and the purple sessions are the 3 core sessions of Evo that happen 2 hours a month for 3 months. And from this, you'll enter at the beginning at Formulate. You'll move through those 3 sessions. A lot of other things going around from the project and finance input as well. And you'll come up ultimately with a prioritization of all of the changes, factor for risk, strategy, quality and resources, and capacity for change. And these come from 3 tools that Evo has as part of its structure. You'll notice that the landing is before the transformation takes place. It's because depending on the scale of change that needs to be mapped, it's going to take different elements of time. And obviously, we want to measure the information, and the clinical teams all want to experience that change and see if it's working, as well as the patient feedback as well that needs to be collected. So we do the landing show and tell before the project transformation hits off. And then the last thing to happen in that green section is the impact assessment per specialty. So there's 3 tools that exist, and currently over the summer at some point we will be publishing these 3 tools in isolation of the framework. So if you think about the framework as Evo Heavy, this will be Evo Light, but essentially this piece of software will allow you to create your value measures. So what does your good look like for your maternity services or otherwise? And you write that down, aligning to the clinical outcomes, patient experience, and patient safety measures in the value equation. You also weight those measures. So this is how we're going to mark and see that the solutions you come up with, or we come up with as an MBT, you come up with as an NDT, are prioritized against each other. What impact will that have on clinical outcomes? What will that look like for patient experience? These sorts of things. So that first measures tool happens in that first session. Then you go through, you run through the evidence. You've then got bona fide opportunities for transformation. And you'll use the priorities tool to map the prioritization of those changes. And you'll move forward to implement the transformation, and the impact tool calculates the impact. You'll do a reassessment based on those original value measures as well. And I've got a show and tell in a couple of months with this piece of software and the tools. We're planning to roll it out for anyone that wants to use it, regardless of the projects you're doing. Hopefully as an enticement to take on the entire Evo project as well, because that structure tends to protect the time and allows the due diligence that's needed. I'll share the pack so you can have a look at some links and animations that I made that could do with more production value, but they get the message across. And we've got our expected outcomes there as well as obviously the financial and quality outcomes that we've seen from various trusts that have taken part in this over the years. We also see an MDT formed that has a consolidated language of value improvement rather than butting heads on quality and finance all the time. These are some of the specialties that have undertaken the process. This is one example from a mental health trust, because they're always a little bit underrepresented in these things. So if there's any mental health conditions out there, we can do it too. Just we have the data available to be able to do it. You can see the DNA decrease and the radiology test decrease and the benefits there. I want to try and keep on time, so I'm going to blast through and you can have a look at these as well. There's case studies online, and we have case studies from the pilot as well. See here that this transformation using text reminder service and 15-week sprint recovered 821 clinic hours. This is just ultimately what comes from MDTs working together in a lean format. These are the pilots, and you can have a look at them on the website as well. This is my final slide. Sorry, it's such a flying visit. I hope you're enjoying the rest of the day. Ellie, thanks very much. Cheers.
Thanks, Rich. Rich has got another appointment he's got to fly off to now. So I will drop his email into the chat, and any questions.
Oh, just on that one that popped up, Ellie, I'll just say it's entirely free. So the only burden of application and access is getting your board supported and supporting an application. So just let us know. Thanks very much, Ellie, and thanks for having me.
Cheers, Rich. Have a good one.
Bye. Cheers. Bye.
Yeah, I'll put Rich's email in, so any questions he's happy to answer, send them on through to him. I think, James, are you on the call? Just check. But we've got James. Hello, James. So we've got James Ransom on the call next, who will be doing a session on clinical coding. So James is from East Suffolk and North Essex NHS Foundation Trust as a clinical coding training manager. So if you're good to go, James, I will pass it over to you.
Absolutely. I'm ready
Great,
to
thank
go.
you.
Okay, so I'm going to talk about clinical coding, and this is from a clinical coders level. So there's been lots of focus on some of the sessions that I've seen today on what happens after the clinical coding. So this is kind of what happens at the clinical coding level, really. So my name is James. I've been a clinical coder since 2012. I passed my exam in 2015, and I've actually been a trainer since 2018. So I've had quite a bit of experience with clinical coding, and throughout that time, it's amazing to see kind of how much the job has changed as well. We've recently implemented a electronic patient record system, so handwriting is no longer an issue for us, but these are things I'll touch on a little bit later. Before I kind of talk about clinical coding, though, I would like to just gather a little bit of knowledge about what experience the audience has in clinical coding. So if I could have just a quick I'm a clinical coder, or I know a little bit about clinical coding, either in the chat or on the mics. I'd like to know if there's any other clinical coding colleagues out there. SNOMED, yeah, SNOMED is a clinical coding tool that we sometimes use. No knowledge, none, very little. Well, that makes it easy for me because quite a few of my slides, I was worried that they'd be patronising in a way, but yeah. So this is the right presentation for us then. So we're going to talk today, whiz through some of these subjects. We're going to talk about what clinical coding is, the actual clinical coding process, uses of coded data, the impact of words, Barry Hazard. So we're going to be becoming his fate and we're going to be coding his fate. So there's a little bit of interaction there. I'm going to ask you to pick what's happened to Barry. Then we're going to talk about the training, the NCCQ examination, and we're going to talk about after the NCCQ examination, the coders then go through audits, regular audits. So let's start from the beginning. What is clinical coding? So this is NHS, the classification service definition of what clinical coding is. So it's the translation of medical terminology that describes a patient's complaint, problem, diagnosis, treatment, or other reason for seeking medical attention into a coded format. Basically, we read what the clinicians have written in the notes and we assign codes to that. So we do it using two classifications. We have ICD-10. This is for diagnosis, basically diagnosis and complaints and anything else that the patient's kind of got wrong with them. Oh, I've skipped forwards there. Very sorry. And then we have OPCS. So this is for the treatment of like procedures, interventions, and any treatments. So the pictures that I've got on there are actual kind of physical images of the physical copies of the. So we used to code them using books, but recently OPCS has become fully electronic. So it's kind of forced coding departments to use the electronic versions and not kind of. It's good for the environment, isn't it? So a clinical coder codes each individual consultant episodes. So the patient comes into hospital and then the patient is discharged at some point. Throughout that period, the patient could see individual consultants. So if they came in with a broken leg and then the patient had a myocardial infarction, a heart attack, then they'd be transferred to a cardiology consultant. Those are individual consultant episodes. So we assign codes depending on what happened in the individual consultant episodes. It's like a book. We're coding the different chapters of the book according to what happened in that period. So the patient's hospital stay is called a hospital spell, and we would code the individual consultant episodes using these two classifications. So we assign diagnosis, including comorbidities, and procedures. The procedures can involve things like CT scans, MRI scans, and then we assign all of these codes, and then they go through a software, and the software then generates another code called an HRG code. That's probably something that you're more familiar with. So the HRG code can change according to how many comorbidities the patient's got, how complex the stay has been, how long the stay has been. So there's lots of things that goes into this HRG code. And then the HRG code does have the price attached to it, and that's how we get our shmoney. So let's look at a coded episode then. So this is an example of what a coded episode looks like. So this patient has acute appendicitis. They have a couple of comorbidities there. We've got type 2 diabetes, and we have essential hypertension. And then if you look a bit further down, you've got the procedure. So they've had an emergency excision of an abnormal appendix. So some people are like, why does that say abnormal appendix? We can actually code if a patient's got abdo pain and they open the patient up and they see, oh, the appendix looks normal, but as we're here, we might as well remove it anyway. So there is a code for a normal appendix as well. And then you can see at the bottom there, we've got the HRG code FF37D, and that's got a tariff of 2,846. So that's the payment scheme kind of price for that HRG code. These screenshots are from the old HRG packages, so it might vary a little bit at the moment, but for us, still right to put on the slide. So I just saw a question. I will answer the questions as I go along. If a patient is on the same ward for a number of weeks and the consultant changes on a weekly basis for that ward, would you still code per consultant episode for that stay on the same ward? If it's the same speciality, no. So they'll have their lead consultant. So if it's the same speciality for that ward, it'll just be under that lead consultant. And then if the care needed to change for any reason, so the speciality changes, or a different consultant comes in to perform surgeries, then that's when the consultant episode would change. So that's when the coding would change. So here are just some uses of clinical coding data. I won't go into too much detail on these. So clinical governance, I'll just pick out their mortality data. So for example, certain codes, if we assign certain codes such as palliative care, then that will make that more of an expected death. So it'll kind of level out the mortality data. Quality improvement, so clinical research, treatment effectiveness, epidemiological studies, took me ages to nail that word. So this is things like health trends, etiology studies, or clinical indicators. Benchmarking, so we can compare ourselves against our sort of our local hospitals or local trusts. Case mix planning, so development of new services and our financial flows. National tariff income, that's a bit of an outdated term, so it's the NHS payment scheme, and cost analysis. Other things that I use clinical coding data, so freedom of information requests. We work with our freedom of information requests team if they've got a request saying how many patients came in last year with lung cancer and were smokers, for example. I can provide the freedom of information team with the codes, and then they can search the codes for that data. So words basically. Coders love words. We need words. And the next few slides kind of highlight how important it is for the clinicians to give us as many modifiers, that's what we call them, as possible for a disease. So we've got here, if the clinician just stated hepatitis, the code would be K75.9, inflammatory liver disease unspecified. If the clinician said acute hepatitis, that would be K72.0, so it's a completely different code. Acute and subacute hepatic failure. If the patient had alcoholic hepatitis, then that would be K70.1. So we've got the just one word changing there, and that gives us 3 different codes. Now I've put these through a kind of like a dummy episode. So hepatitis, if that was the only code assigned on just a basic episode, that would be £1,036. That's what the HRG would kind of would be generated. If it was acute hepatitis, then that would generate £611, and then again alcoholic hepatitis £611. So there is I mean, this kind of defeats the object, so we want more specific terms, but there is a financial impact if we're missing modifiers and if we're gaining modifiers as well. And the same goes for procedures as well. So if a clinician just wrote colectomy, that would be one word. If they said sigmoid colectomy, that'd be a different code. If they said hemicolectomy, that'd be a different code altogether. So it works for procedures as well as diagnosis. So the next few slides, again, I put through a dummy kind of episode. So we've got our acute appendicitis back. So if a patient had acute hepatitis, appendicitis, then we'd have K35.8, that's the diagnosis code, and then we'd have our emergency excision of abnormal appendix. I must say I didn't actually change the person who was doing this, so excuse the fact that it says a midwife did this. I know they're extremely talented, but I don't think they're removing organs just yet. So if we've just got a acute hepatitis with an emergency excision, that would be the HRG code would be £2,721. If we had a comorbidity, I've chosen here other obesity, which is morbid obesity, then you can see there the total price at the bottom, the HRG code goes up because we've got more comorbidities, so more complex comorbidities. The score here, the higher it is, the more complex comorbidities the patient had. And then the price you can see there is now £3,096. If we just added one more comorbidity, so if the patient had respiratory failure, would add that to the coding, and you can see there the price is now £3,569. So these are, like I said, these are dummy episodes, but that just shows the more kind of information that we have, the better the income, the more accurate the income. So there's a little kind of activity I'd like us to do now. Obviously, we've got a bit of a time restraint, so if we could have answers as soon as can. So meet Barry Hazard. He's a nice fella, Barry Hazard, but he is a very unlucky guy. Things always seem to happen around Barry Hazard. And another thing about Barry Hazard is he's a bit of an optimist. So Barry is now surrounded by lots of hazards. He's on a beach. So what I'd like you to do is I'd like you to type in the chat an injury that Barry has sustained and how he sustained an injury. So you could say open wound of such and such by stepping on such and such, or I can see there's a deep drop there. So if we could just have some really creative injuries, then what we're going to do is I'm going to show you how a coder would code them in real time using the classification. Sunburn, so Gary's leg, sunburn, that's a good one. So what I'm going to do, trip and fall, broken leg. Electrocution. Well, we've got loads. We can probably do a couple. So I'm going to go with sunburn first. Gary, what degree of sunburn shall we give Barry? %60%. So that will be first, second, or third degree we'll be looking for. So what I'll do, so this is the classification browser. This is basically like our book, so third degree sunburn. This is basically like the books that we use. So we've got third degree sunburn. So if I type in sunburn, you can see here we've got options. So Gary's given him third degree sunburn. So what I'll do is I'll click on that. So this takes us to our alphabetical index. It's basically like an index at the back of a book. Obviously, we don't want to be just flicking through all of the codes because we won't get anywhere. So we've got here third degree sunburn, L55.2. If I click on that, that will take me to the actual code, what the code looks like in the classification. So you can see here, sunburn or third degree. So that would be L55.2. We would also use an external cause code for the sunburn. So with every injury or everything that has happened to the patient due to an external cause, we could add an external cause code. So if I type in burn, you can see here, actually, I might just be able to type in sunburn. And then external causes, there we go, overexposure to sun. So what we're doing here is adding information. This was due to sun, obviously sunburn. So if I click on that, X32 exposure to sunlight, that's the code that would be. Normally these are 4 characters. So what we're missing here is a place of occurrence code. So if I go to the start of the chapter, we know that Barry is currently on a beach. So if I go to the start of the chapter, so we've got our place of occurrence codes here. We've got 0 for home. But if we scroll down to the 8, you can see other specified places as 8. So that was actually, I'll type in the chat the codes that we got for sunburn. I need to go back a little bit. So that was L55.2. And then we had X32.8. So that's basically how to code an episode. I could do that all day, but I don't think I've got time to do that all day. So we'll just go for the sunburn for now. Yeah, there's all sorts of strange and wonderful codes, David. I wouldn't say volcanic eruption is wonderful, but yeah, it's always fun to see what options we got. Okay, so Barry. Sorry, Barry, sunburn today. Back to words. So it's really important that clinicians know that we can't just code anything. So if a clinician said the patient had presumed pneumonia, probable pneumonia, treat as pneumonia, work and diagnosis pneumonia, or impression pneumonia, then we can code that as a confirmed diagnosis. If they said possible pneumonia, query, or question mark, or suspected, or differential diagnosis, then that's not a definitive enough term for a coder, so we would have to code the presenting symptoms. That'd be like cough or shortness of breath. So this is something that we always kind of put across in our doctor's induction events, just to make sure that we need like a definitive term so that we can code effectively. Obviously, we don't want the clinicians to say presumed if they do actually mean likely. If they don't want us to code it as pneumonia, then by all means use these, but we want them to know that there is a difference in terms of the coding if we use these terms. Impression. Now, impression is local to my trust. So we actually have a local policy to say If a clinician uses the term impression, we can code that as a definitive diagnosis. Other trusts may not have that local policy in place. Another issue that coders often have. Now, this is actually an extract from one of so we used to have a scanning system. This is a real life extract from one of those. So handwriting was a massive issue. I say was because we're now using a fully electronic patient record. Not all trusts have that, so trusts are still using physical paper. So this is one of the problems. What this actually says is abdo pain, RUQ, so right upper quadrant, vomiting, unwell 5 days, reattended, not admitted, pain better, much better, now better, except loose stools, bowels open 1 to 2 times a day, no blood. So that's just another one of the challenges that clinical coders can face. Yeah, so as Lester has just pointed out, the World Health Organization do publish the ICD-10, so that is used globally. Other countries use it in different ways. So we've got our own UK rules, so we follow our national standards. OPCS, so the procedure classification, that's an NHS thing. So those are developed by NHS to kind of code our NHS procedures. I'd never thought you were laughing at the victim, Melanie. It's all good. I just said that was a funny thing. That wasn't funny. Training. So each trust have their own training programs. We don't have like a standardized training program. We do have a standard kind of first course that a trainee coder would need to go on. So that's a 21-day course, up to 25. And it's called the Clinical Coding Standards course. Basically, we go through every chapter of the classifications and talk about the national standards that we need to follow during each chapter. And then it is up to kind of hospitals or trusts to come up with their own training program for ongoing training. So this is just an extract of the training program that we have here at ESNEFT. So we have a modular training program. Basically, a trainee goes through each module and learns each of the chapters standards, putting it into practice in real life coding. Alongside coding these, we've got workbooks for each module. So for example, a trainee comes in and the first thing they do is endoscopy coding because it's quite kind of low complexity, high volume episodes. So they come in, they start coding endoscopies. Their work is checked by a mentor and they are given a workbook for endoscopy coding. So that kind of covers all of theory and lots of practical exercises in there. They're on each module for around about a month, but they need to be signed off on the module before they move to the next one. So they need to pass an audit of endoscopy coding, and then they also need to pass an assessment for the workbook. So I basically give them a blank copy of the workbook, all electronic, for them to fill out, and then I mark against those. Now, the whole point of the training is to pass the exam. The exam is a very difficult exam. There are 2 papers to the exam. So we've got here, this is the practical exam. You can see there, it's 3 hours long. And then we also have paper 2, which is the theory exam. You can see it's done on the same day, so 9:30 a.m. to 12:30 p.m. would be the practical, and 1:30 to 6:30. This was actually the exam that was sat in September. There's 2 of these a year. You've got September and you've got March, and they're very difficult to pass, I've got to say. So for the practical exam, you need at least 90% to pass. if you get over 95% or 95% and above, then that's actually a distinction. And then for the theory, it's a little bit lower. So you've got 70% to pass that paper, and then 85% for a distinction. It is a very, very difficult exam to pass, but passing it would make the coder an ACC. So they would then be known as an accredited clinical coder, which is it's gold standard really. It's the aim of a coder is to become an accredited clinical coder. Some trusts offer a salary uplift. So the structure that we've got here at ESNEFT, if a clinical coder passes the exam, they are then uplifted to a higher salary. Also, it opens up new career pathways. So accredited clinical coders then can go on to become auditors or trainers. So for an auditor or a trainer, you need to be an accredited clinical coder for at least 3 years. Locally, we also offer another type of career to accredited clinical coders. They could become divisional leads. So that's a coder kind of in charge of looking after a division. So our women's health division, divisional lead, she kind of liaises with lead midwives, consultants, just to sort out any documentation issues and any local guidances that are needed. Now, once you're a clinical coder, it doesn't stop there. You then are audited. So each clinical coder has an individual audit, and we also have a departmental audit. And we need to meet these kind of levels. So this is a DSNP audit. We need to meet at least 90% primary diagnosis to meet the standards, 80% secondary diagnosis, 90% primary procedure, and 80% secondary procedure. The aim for us really, because we've met the standards, not luckily, we've got a really good coding team, brilliant coding team. So we've met the standards kind of consistently for the past however many years. I think 2019 we needed to kind of improve, and we did, and we've stayed there. So now our target at ESNEFT are to meet the standards exceeded. That's not easy. That's not easy at all. And then just really quickly, I know I'm now hitting my time, but the workload, I thought I'd kind of put the workload up there. I have seen that somebody's mentioned potential use of AI for coding. It'll also read doctor's handwriting. Absolutely. I know there's some AI solutions out there at the moment, but they still need a little bit of work. One thing about clinical coders is quite a few clinical coders who are worried that AI are going to take our jobs, but that's not going to be the case. They're not going to take our jobs, but our jobs may change. So the ESNEFT workload over the last few months, you can see these are our number of admitted patients. So everyone who's been admitted will also need to be discharged. Doing this work is a workforce of 37 coders at ESNEFT. So we're across 2 sites. We're at Ipswich and Colchester. Among these 37 coders, we have 2 trainees. We have 26 accredited clinical coders. We have 8 non-accredited coders. We have 3 auditors, 6 divisional leads, 1 trainer manager, 1 trainee trainer, and we've got a partridge in a pear tree among there as well. So that is basically it for my presentation. I don't know if we've got any time for questions, Ellie. I'm happy to answer.
We'll be going for a break now. So if you're
Okay.
happy to stay on,
Absolutely.
we'll come join back at 3 o'clock. But if anyone's got any questions in the break, and James, you're happy to answer, then yeah, please go ahead, and we'll meet back at 3. If not, thanks.
Thank you, Joanne. Very nice. Does coding mainly occur at the point of discharge using the discharge info for coding? Now, a common misconception is that coders only code from discharge information. We don't. So the patient has to be discharged in order for us to code it, because we code after the kind of episode is completed. But we look at everything. We look at all of the clinical notes. We look at the nursing notes. We look at all of the kind of documentation that other teams like dietitians, physiotherapy teams, we look at everything. We look at operation notes. So our job is to make sure we extract as much specific relevant information as possible, and we code everything really. If we're just coding the discharge from discharge summaries, for example, there'd be a lot of information that would miss out on, because that just gives you like a snapshot of that episode. Thank you, Melanie. Barry definitely needs the best. How useful is the coding for services which are block funded and outpatient based? Outpatients, I'll start with outpatients. So the trust that I'm with are now with Epic. So outpatient coding. So the clinical coding departments do not code outpatients. That's normally done by kind of interdepartmental staff, so receptionists, or if you've got a system like we've got, it's done via like an automated process. I'm not 100% sure how useful that data is, because we don't really use that data as a clinical coding team. So it will have to be sort of your finance managers would probably be able to answer that. But yeah, I know that the coding is actually done by other means, not clinical coding departments. And also block funded as well. I know that some trusts are block funded. We still need clinical coding for data, as that data still needs to be entered into the certain systems. Obviously, the finance side of things is kind of taken out, but the data is still needed. Our primary functions, obviously, the finance side of things, but as I said, on that other side, there are so many other uses of coded data that if we just stop coding because block funded contracts, there'd be a lot of sort of important data missing from people's information. What processes are in place to provide assurance that non-accredited clinical coders encoded correctly? So that is all down to audits. Each coder here has their own individual audit. If there's any kind of training requirements highlighted on those audits, then obviously would give them training. Now, the audit, including individual audits, we base our DSMP audit kind of targets. So these are the same metrics we kind of use for our individual audits. So if the non-accredited coder doesn't meet the primary diagnosis of 90%, then they're given support. They're given as much kind of support as needed to get them above that 90%. Also, we do have a really good structure here at ESNEFT. I can only speak for ESNEFT, but if a clinical code has a question, we make sure that they are comfortable with asking a senior member of the team or a divisional lead those questions, and make sure that they are clear on all of those. So yeah, I think that answers your question. Also, every 3 years, a clinical coder needs to do a refresher course delivered by an accredited trainer. So whether they're an accredited clinical coder or a non-accredited clinical coder, they still need to have refresher courses as well. And during that course, we can highlight if there's any areas that need kind of working on. Thank you for all the nice comments. How do you get a new code created for a new treatment modality? So that actually goes through a process. These classifications, they can't just be added to. There's only a kind of, they release OPCS, which is the procedure book. They release that every 5-ish years, 3 to 5 years, and that would be a case of sending. I think if you go to the classification website, you can then kind of recommend new procedures that are added to the next edition, but that has to go through a huge process. I don't know too much about that, but it has to go through a huge process, and they liaise with their kind of clinical team to get new codes added. There has been so the latest edition of OPCS has had around 5,000 changes. So this is new codes has been added to that. So and actually, I'd say it is the best one so far because it has lots and lots of codes. There's very rarely do we get a procedure where we're like, I don't think there's a code for this, because if there isn't a specific code for something, then there are they're called catch-all codes, like residual codes, where it be other specified operation on appendix or other specified operation on tooth. So should AHPs be as careful in their wording as well, or does it have to be confirmed by the consultant? Sorry, what's an AHP?
Hiya, sorry, that was me. So it's an allied health professional. So thinking of therapies.
Okay, therapies. No, so if there's therapies team, we basically at ESNEFT we look to see if a physiotherapy has been given, or any physiotherapy treatment has been given, or occupational therapy, and then we assign a code for that. But when it comes to the actual diagnosis, we do go to the documentation from the clinician. So you don't need to be careful about your word and as such, because we look at the kind of the clinician's documentation for that.
Thank you.
No problem. Thinking of treatments we do in radiotherapy that have no charging codes. So we actually code radiotherapy, and we do have new radiotherapy codes, so it might be worth kind of looking at those brand new codes. Actually, our radiotherapy coding is quite robust as well. We have we have the code for the delivery, the prep, and any type of special machine that is used for radiotherapy. So if the radiotherapy has been done as a inpatient level, then all of that gets captured. I mentioned consistent standards through examination, but also that there be some variability between organisations depending on local policy. Yeah, no, that's exactly right. That's a really good point. Different trusts have different local policies. So I could just think of an example. At ESNEFT, we've got a local policy saying that we can interpret BMI scores. I know a lot of trusts have got a similar local policy, but there could also be other trusts that don't have that local policy, so can't interpret BMI scores. But yeah, I'm afraid I don't really have an answer for that. It's known that trusts do code certain things differently. But we do have one set of standards for ICD-10, so the diagnosis classification, and OPCS, and these are the standards that need to be adhered to. There are quite a lot of standards. So those are, so I can quickly show you what they look like. I'm not eating into another one, am I, Ellie?
Oh, sorry, I was on mute. No, you're all good. We're on a break at the moment anyway, so we're back. Next session's at 3 o'clock.
Okay, I'll go for a little bit longer. So these are the standards that clinical coding departments must adhere to. So clinical audit or clinical coding audits are kind of done against these standards. So you can see, so we've got chapter 4, endocrine nutritional. So this is a standard for diabetes mellitus. This is basically if you if you go away from these standards and code differently, then it's wrong. Basically, that's wrong. Other little things like I said, the BMI local policies, that's harder to kind of make consistent nationally, but so long as we're assuming, not assuming, so long as we're adherent to these standards, then that's that's kind of it really. And I can show you OPCS. So equally, this is the standard reference material that we have for OPCS. And if I go to radiotherapy, I can just show what our radiotherapy standards look like. Thanks. So just to answer the other question, this is what our radiotherapy standards look like. So we must code, we must adhere to these radiotherapy standards. So yeah, they're quite robust codes there. You can see we've got lots of information here. You must code this, 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 this. If it's given under general anesthetic, must code that as well. Right, I think I'm done with the questions. So if there's no other questions, thank you very much for today. Thank you very much for the interaction. I didn't expect Barry to get so many recommendations. I thought it was going to be I was going to ask and then sort of be waiting, but there's loads on there. Poor Barry. But yeah, thank you very much indeed.
Welcome back, everybody. So we will be joined now by Ramandeep Kaur, who is from the Royal Wolverhampton NHS Trust for a session on Introduction to Primary Care Finance. So, Ramandeep, are you there?
Hi, I'm here. Yeah, can you hear me?
Hello. Yes, can hear you all good.
That's all great.
Thanks.
Okay, thank you. Okay, so primary care. Hi, everyone. I'll be going over primary care finances. There are a few hyperlinks in this PowerPoint, so if you have any spare time, I'd highly recommend you visit the sites for more detailed information on the topics that we're going to be going over today. Okay. Oh. Okay, so primary care services are medical services available to the public as first points of contact. Patients generally are treated at these primary care settings for non-emergency medical needs and routine checkups, or receive referrals to secondary care from these facilities for more advanced or specialized diagnoses and treatments. Examples of primary care services include general practice, community, pharmacy, dental and optometry services, which are usually located in your local areas and communities. For the purpose of this presentation, I'll be focusing on general practices and its finances. So general practices are small to medium-sized businesses you will find situated locally around your community. They can be managed by individual GPs, or two or more GPs can come together as partners and manage the practice under a partnership. Other staff members with other roles can also become partners and acquire a general practice as long as one of the partners is a GP. In England, most general practices are owned by partners. Partners are jointly responsible for meeting the requirements set out in the contract for their practice. Some partnerships can also merge, meaning they take on additional contracts, creating a super practice. An example of a super practice is our health partnership, which owns over 30 practices and surgeries across the West Midlands and manages over 280,000 patients. Organisations and NHS bodies can also own general practices. Examples of clinical and non-clinical staff you may encounter when visiting a general practice are listed on the slide. So general practices must hold NHS GP contracts if commissioned by the NHS. These contracts specify the available income streams and the mandatory requirements and services required to be delivered by the general practice, as well as additional optional services that a general practice can agree to deliver for exchange of payments. There are three core types of GP practice contracts that determine how primary care services are managed and funded. These are general medical service contracts, personal medical service contracts, and alternative provider medical service contracts. GMS contracts are the most commonly used contracts in England. These contracts are agreed yearly at a national level between NHS England and the BMA, which is the Union for Doctors and Medical Students. Next is PMS contracts, which are similar to GMS contracts. However, they offer more flexibility regarding required deliverables because the contracts are created locally by ICBs, who tailor the contracts to local needs whilst maintaining within national guidelines set in GMSs. PMS contracts are the second most common, but not as common as they previously were. The third core contract type, APMS, is the most flexible and allows ICBs to enter into contracts with organisations such as private companies to provide non-core primary care responsibilities, such as providing healthcare to people who are homeless or to asylum seekers. A few main points from the 26-27 contracts include goals to increase focus on GP capacity, supporting the shift from treatment to prevention through changes to QOF and vaccinations, as well as promoting practices to prioritise clinically urgent needs. For this year, investment in the GP contracts will increase by £485 million, bringing the combined total estimated contract value to £13.863 billion. This provides a 3.6% cash growth or 1.4% real-term growth relative to the GDP deflator. So the types of income a general practice will receive will depend on what has been agreed in the contract. The income will be for core activities and additional income for optional activities delivered by the practice. A huge chunk of the income is received through a monthly global sum payment, which is capitation based, meaning general practices will receive a fixed amount of income per registered patient, regardless of how much care is delivered to an individual. Patient population sizes are then weighted to consider affecting factors aiming to make the allocation of funds more fairer for the practices. The weighting is based on factors from the Cahill formula, such as the patient's age and gender, the rurality of where the practice is, number of patients in a nursing home, and common disease prevalences in the area. The global sum payment is updated quarterly to reflect changes to the practice's weighted population during the year. For this year, the rate is £130.07 per patient. Last year it was £123.34. There is also a London waiting allowance, which provides the practice an additional £2.18 for each registered patient whose home address is located in Greater London Authority area. In addition to this, the value of the global sum payment can be reduced if practices decide to opt out of providing minor surgery and out-of-hour services. Some practices may find this reduction in income is more cost beneficial for the practice because the reduction is much less than the expenses the practice could anticipate. Oh. Is everything still okay? Yeah, I think so.
Yep, you're all good.
Oh, that's fine. Sorry about that. Okay, 1 second. Sorry. So in addition to this, the value of the global sum payment can be reduced if practices decide to opt out of providing minor surgery and out-of-hour services. Some practices may find this reduction in income is more cost beneficial for the practice because the reduction is much less than the expenses the practice could anticipate if they were providing minor surgery or out-of-hour services. On the screen is the percentage decrease practices can experience for opting out if they're on a GMS contract. So 0.6% for minor surgery and 4.7% for out-of-hour services. QOF stands for Quality and Outcome Framework. This is another type of payment general practices receive. Participation in QOF is voluntary and the income is rewarded to practices based on how many points they can achieve. Population size of a practice also impacts the maximum amount of income available for them. There are two types of payments practices will receive. The first payment is called aspiration payment. These are upfront payments paid to practices monthly. The amount of aspiration paid is calculated using either a calculation based on 80% of the contractor's previous year's unadjusted achievement payment, or can be based on the total number of points that a contractor has agreed with NHS England that it is aspiring towards for the current financial year. The second payment is the achievement payment. This is usually paid in the first quarter of the next financial year after points achieved have been finalised. Depending on how many points the practice has achieved, the achieved payment can be additional to the aspiration payments or can be a clawback if the practice did not score enough points. So this slide shows the QOF areas split between clinical domain and public health domain, as well as the maximum available points up for grab per area this year. In total, there are 582 points to achieve this year. Each area has assigned indicators or targets which the practice are trying to achieve. Practices score points based on the percentage of their relevant patient population that successfully receives the targeted care or meets the health outcome. Per area, there are upper and lower thresholds. Practices need to meet the lower thresholds to begin earning points. If the practice doesn't achieve the lower percentage, the practice receives no income. Practices that hit the upper threshold for these targets get maximum points, and if the practice achieves the target between the upper and lower thresholds, the points are prorated. The base value of a point is £227.95. However, the value a general practice actually receives per point can be adjusted based on CPI and APDF adjustments. The purpose of QOF is to improve the quality of primary care and reward GP practices for delivering high-quality, evidence-based interventions to their patients by encouraging GPs to focus on preventative care and managing long-term conditions so they can catch small issues before they become major emergencies. An example of a new indicator is from the obesity area clinical domain. Practices can receive a maximum of 5 points for referring eligible adults with obesity to weight management programs if referred within 90 days of BMI recordings. The lower threshold for this indicator is 10% and the upper threshold is 30%. This means general practice will receive the full 5 points if they meet the 30% threshold. So practices will aim to refer 30% of their eligible adult patients with obesity to weight management programs to achieve the full points from this indicator. There is more in-depth detail accessible from this link. And the PDF also lists out all the targets per area as well as shows the lower and upper thresholds, so really useful. General practices can also receive income and reimbursements through joining a primary care network. Primary care networks, or PCNs, were formally created in 2019 and are groups of GP practices that work together and with other health and care providers, usually located close to each other and under the same ICB commissioner. Their main goal is to increase collaboration among primary care providers as part of an integrated neighbourhood team to provide better proactive, personalised and coordinated care for patients closer to their homes. Over 95% of general practices in England have joined a PCN. By joining a PCN, general practices can receive further streams of income in relation to their PCNs. The PCN payments described on the slide are paid to a PCN's nominated payee. This is basically a practice that has been designated to receive the income on behalf of all the practices in their PCN. The nominated payee can be responsible for funding the costs in relation to the funds received or can transfer funds to the other practices as required or agreed between its PCN practices. So one of the fundings the nominated practice payee will receive is called core PCN funding. For 26-27, the value is slightly over £3 per patient. The goal of this payment is to provide funding for practices to be able to increase collaboration with the practices in their PCN. In addition to this payment, the nominated practice payee can also receive enhanced access payments, which is currently just under £9 per the PCN's adjusted population as at 1st January 2026. This payment is for PCNs who deliver extended appointments outside of the standard core hours of 8 a.m. to 6:30 p.m. So for evening appointments between 6:30 p.m. to 8 p.m. or Saturday appointments between 9 a.m. to 5 p.m. This does not mean all practices inside a PCN have to deliver extended hour appointments. It's a decision made collectively by the PCN on how they are going to deliver the extended hour appointments, whether one practice will remain open during the extended hours, and whether contracted doctors or e.g. locum will be used to deliver the appointments. This can then mean patients visiting practices for their appointments during the enhanced hours are directed to a nearby practice that has agreed to remain open during the enhanced hours. Patients are made aware during the appointment booking stage if they will be required to visit a nearby practice. PCNs can also receive a care home premium payment paid to the nominated practice payee. This payment is paid per care home bed covered by the PCN that has been registered with Care Quality Commission, CQC. The payment is paid to help cover additional costs for providing services to patients in care homes. The current rate for 26-27 is £133.158 per bed, which is about £11.10 per month. In addition to these three funds, all practices in a PCN that have signed up to the network contract DES are automatically opted into receiving the network participation payment. The rate of this funding for 26-27 is £1.761 per weighted population as at 1st January 2026. This payment is not paid to the nominated practice payee, but instead paid to each practice that has signed up to the DES contract. Practices that have signed up to the DES are called core network practices. These practices have the option to opt out of this payment. However, to opt out, core network practices must leave the full DES contract, meaning other associating funds flowing from DES will also be cancelled. So the rates I've just mentioned and that are showing on the slide are all the yearly rates for the four payment types. PCNs will receive the monthly value of these payments per month to keep cash flowing. DES stands for Directed Enhanced Services, and this is a type of contract that practices that are a member of a PCN can sign up to for extra financial benefits in exchange for delivering enhanced services listed in the network contract DES. So a general practice agrees to provide more services on top of their core services required from them from their core GMS or PMS contract. Their core primary medical services contract, the GMS or PMS, is modified to also include provisions of the network contract DES specifications. Examples of enhanced services a practice could provide and receive reimbursements for are shown on the screen. DES is nationally agreed and designed to improve patient care by addressing national health priorities. So on this slide, we can see more examples of enhanced services. These are called local enhanced services or locally commissioned services. These are catered to the local health needs and developed by ICBs at a local level. As they are locally acknowledged, funding and conditions will vary depending on what has been agreed with your local ICB. Under the network contract DES, a PCN is entitled to fundings to support the recruitment of new additional staff to deliver health services. This scheme is called Additional Roles Reimbursement Scheme, or ARS. The intention of the scheme is to grow additional capacity through new roles and by doing so help to solve the workforce shortage in general practices. It is not to fill existing vacancies or subsidise the costs of employing people who are already working in primary care. Therefore, for a member of staff to be qualified as an R staff member, there are a few conditions that need to be met that then impact whether reimbursement will be granted and how much funding is reimbursed to the practice. The practice will first agree with the Commissioner a workforce baseline when they first register under DES. The baseline then helps Commissioners understand what staff roles are core for the PCN and so which staff members or roles will be additional for the PCN. To qualify for ARS reimbursement, the additional staff members will need to be appointed to roles that are agreed by the Commissioner as reimbursable through ARS. This slide shows some of the reimbursable roles and bands that are accepted for ARS reimbursement. Then monthly, the PCN will submit claims to receive the reimbursement in arrears and provide any relevant updates that may have occurred to the employee through the Futures online portal. The maximum entitlements a PCN can receive is proportioned based on their PCN's weighted population share compared to national population. There are also maximum limits to each role as shown on the slide. During 25-26, newly qualified GPs were added to the list of claimable roles. This year, it has been decided to extend this to allow PCNs to hire qualified GPs and claim their costs for reimbursement. So another type of payment receivable under the DES contract is IF. This is the investment and impact funding and is an incentive scheme focused on supporting PCNs to deliver high quality care to their population and the delivery of the priority objectives mentioned in the NHS long-term plan. The funds operate in a similar way to QOF, rewarding achievement of PCN objectives through a point-based system. There are 48 points and each point base value is worth £198. There are two domains. One is in relation to tackling health inequalities and the other is in relation to cancer. As with QOF, IF also has upper and lower threshold goals that determine how many points the PCN has achieved for the year. So something new for 26-27 is the GP reimbursement scheme. This scheme is funded using funds that were previously known as capacity and access payments, which were a part of the DES contract. Now, this new scheme this year is a part of the main primary medical services contract. Practices are required to make claims for the eligible GP or GPs through the portal. To be considered eligible for the reimbursement, the GP must be newly hired or has increased their sessions or was previously funded by the capacity and access funds, so is switching over to the reimbursement scheme. Depending on how the GP qualifies for the scheme also determines the reimbursement amount. The GP must also be performing clinically same-day urgent access appointments in those sessions. When submitting claims, practices will have to show evidence proving the sessions are being utilised as required by the scheme. A few more incomes that a primary care service can receive are on this slide. Primary cares can receive drug income for administering and prescribing PPA items, also known as personally administered items. Ooh. Oh. There are, of course, conditions surrounding which PPAs will be reimbursed, and calculations are done to figure which value a practice will receive for administering or prescribing the drug. During flu season is when practices experience an influx of costs and also income for providing the flu vaccines. Practices have to submit claims through NHS Business Services Authority portal, and it is advised that claims are distributed among multiple prescribers to keep each prescriber below the threshold of 460 items per month. This is because if a person claims more than 460 items in a month, the person will endure a reduced dispensing fee reimbursement for each claimable item after the 460th. By allocating claims this way, especially during flu season or other high volume periods, you retain the higher dispensing fee reimbursement for as many items as possible. There is also a winter access fund known as WAF, which is locally delivered funds for the winter period. The goal of WAF is to improve access to urgent same-day primary care services by increasing capacity and GP appointment numbers achieved by the practice during the winter period, where practices see an increase in appointment requests. So GPs will use the funding to either increase bank sessions or hire more locum. Practices can also receive training income from ICBs for providing training to student GPs. Some universities may hold SLAs with practices too, and so the university will also provide funds in exchange of the practice letting the university student conduct placements at the practice. As well as trainer funding, staff at the practice who want to study may also have their courses reimbursed by the ICB. This can be for GPs and other staff such as nurses and pharmacists. So it's always worth checking with your local ICB if they are willing to pay for a staff member's course fees. Primary care organisation administered income is in relation to funding locum cover covering absent GPs who are absent for sick leave or maternity, paternity, adoption leave. Practices will need to submit claims to the ICB for reimbursement. In addition to this, you can get the practice's rent, rate bill and water bills reimbursed. Claims are submitted to local ICB and payment will show in the monthly primary medical services contract statements. And finally, general practices do receive income through delivering care to private patients. The income is totally separate from the main income from ICBs. Income is paid, e.g. directly by the private patient or their insurance company, or e.g. DVLA if they're asking GPs to, for example, perform a medical check. Okay, so that was all for primary care as a summary, as an introduction. Hope that was useful and not too confusing. Okay.
Does anyone have any questions at all? So pop your hand up or put it in the chat.
I thought my mic kept going off so that I could hear like a little beep going on.
I think that was someone
lost
coming into the thing. No, you're all good. We could hear you okay.
That's totally fine.
Just wait a minute just to see if any questions come through. It doesn't look like we've got anything come through just yet, but are you happy for people to contact you if they've got anything afterwards? Yeah, great. Thank you so much, Sarah Ramandeep. Thanks for taking the time out for your day. Enjoy the rest of your day.
And you. Thank you so much for everyone.
Thank you. So we're joined by Deborah Miller now, who will be giving us a session on, sorry, just bringing up the agenda, budgets and spreadsheets. So Deborah joins us from Croydon Health Services NHS Trust. I think I've seen you on the call, Deborah. Are you around?
Yes, I'm here.
Thank you very much. Are you all ready to go?
I am, yeah. Are you able to present? Is that what you were doing? Or
I can do.
Oh no, it's fine. I can do it as well. That's fine.
Yeah, great. If you're happy to, then go ahead. Thanks, Deborah.
Okay. So, my name's Deborah Miller. Thank you for holding on so long. It's been a long day, I'm sure you'll agree, but you've just got me and one other, I believe, so you're on the homeward stretch. I just wanted to say as well to Ramandeep, the previous presenter, I can understand now why they have practice managers, because there is a lot involved in GPs, isn't there, in primary care. So this session is about understanding budgets and spreadsheets. It should be straightforward, but as you know, the NHS, it's not always as easy as you think it should be. I've worked at Croydon University Hospital since 2012. Before that, I was at St Helier Hospital. Since my early 20s, I'm fully qualified, certified, and I love the NHS. So that's why I'm helping out today. So the aim of this session is to understand the key principles of setting and managing a budget. I've always worked in NHS trusts, and I see there's a lot of people on the call from BARTS, UCL, and various others. So hopefully my experience will be aligned to where you work. So you've probably heard that there are quite a lot of various departments within finance. You probably wondered what we all do. I can assure you that we're all very valuable. I work in management accounts and planning, which is more about setting budgets, planning for the future, budget setting. More recently, we've been renamed as finance business partners. So we work closely with the various directorates and we plan for the future, try to help the PMO teams to reduce costs. But it's a lot more about planning and getting services aligned, providing services at the cheapest possible cost whilst maintaining quality for patient services, and a lot less about the management reporting. So we prepare management accounts now within 3 working days of the month end. So on your 4th working day, you can have access to all the information for the previous month. And this is so that you can plan. There's no point you receiving financial accounts 3 weeks into the month, because then you've lost 3 weeks already to be able to put any kind of change into place. So that's my department. We help with business cases, which is your next session, tendering. We help with monitoring SIPs as well. Business services is more about contracting. It's getting the right level of income in for the plans that we are being asked to achieve or can achieve. They also do SLR reporting, which you can see over on the right hand side. Basically helps, it breaks down and shows financial information in a different way. So you generally have your management accounts preparing statements for specific costs. So you've got your pay, you've got your non-pay. Service line reporting looks at it from a clinical service point of view, and it brings in all of the external costs. So within running a theatre, you've also got the rent and rates of the building, you've got the lighting, you've got the heating. It brings in everything. So service line reporting and patient level information brings in a lot more detail. It's usually got more of a time lag because it takes longer to bring in all of that information, but it's very interesting sometimes to see and compare your cardiology service and specific procedures that you do with those of neighbouring trusts, just to compare and contrast whether you can do better or whether you're a leader in that service and can actually help other trusts as well. So we help with that within finance. So a lot of SLR reporting, benchmarking and PLICs. Financial services is more what people think about when they think of finance. So they prepare the annual accounts, the balance sheets, the profit and loss. But they're also responsible for paying suppliers, for paying employees, which is obviously very important. A lot of trusts have outsourced that particular sort of processing type role to companies like SBS, but each trust still retains some staff that help out with that facility. They collect the money in, they have petty cash. They also do the charitable funds, which is completely separate from the normal day-to-day running of the trust. Charitable funds have their own separate bank account and are kept very separate, but it's financial services that deal with that. And obviously capital funding. And just to say that benchmarking is literally a comparison of the performance of our trust or individual clinicians and their output with others. And obviously that's very important to check that we're providing the best service, that there isn't something quality-wise that we could be doing better for our patients. So what is a budget and why do we need it? From a clinical point of view, you want to be able to do everything that you can to provide the best service to your patient. And things like budgets can be seen as getting in the way. But if you're fully involved in budget setting, which you should be, then a budget is a plan to be able to deliver the activities that you have agreed with your local ICB for the forthcoming year. So your budget should match what you're planning to achieve for that year. And as such, if you overspend on your budget, then it could well be, and usually is, that you're not going to get any extra income for the activities that you're doing, because you're doing over and above. So then you get into the realms of having to agree ERS funding with your ICB. So it's you have to maintain communication with your ICB, because generally speaking, your budget is your budget and you shouldn't go over it. So part of budget setting involves setting, you monitor it during the year. We do forecasts during the year, just to try to make sure that spending remains as was expected at the start of the year. And if you have a budget that is overspending, then you need to be able to explain as a budget holder why that is happening. Because usually it's something that you're aware of because you were involved in the budget setting process. And similarly, if there's something that's underspending, it may be that you've coded it to the wrong place, or somebody who you work with has coded it to the wrong place, or for some reason the invoice hasn't come in which case your accounting department should be accruing for the cost. So just seeing a favourable budget statement shouldn't necessarily make you excited, because it could be that something is missing. And the NHS, as we all know, has limited resources, and setting the budget ensures that we manage taxpayers' money as efficiently and as effectively as possible. And as the little diagram shows, income must meet or be the same as what we spend, otherwise we're overspent. And as a lot of trusts in London specifically know, there is a big problem with deficits, and that's why we have our PMO teams constantly trying to find new and inventive ways of cutting costs. So budgets enable us to plan for the future, control expenditure, and ensure that the trust gets the best value for money. As a budget holder, you are accountable for all the costs that are incurred against your cost centre. So you should know what is going on with your spend. And the budgets are critical to making sure that we break even at the end of the year and achieve the contracted activity levels. So how are budgets set? Different trusts do it different ways. What's been happening lately, the last couple of years, is that your budget that you have for 1 year is rolled into the next year. But if you had extra funding partway through the year, so it's only 50% in last year, you should receive the full amount in the new year. Similarly, if you found savings halfway through the year, then your new year budget would reduce to take account of the full year. We also add in pay awards, any kind of inflationary changes, just anything that we know about in advance to make that first year starting budget as accurate as possible. So in most trusts, pay accounts for about 70 to 80% of the total expenditure, which is a massive sum of money, which is why as a budget holder you need to be on top of all the staff that are coded to your cost centre. You should know who they are. Oops, I did that by mistake. You should know who they are, and you need to be able to account for the staff at any point in time. So how are budgets set? We have pay, like I've discussed, and non-pay. Non-pay is everything that isn't pay. sounds obvious, but I do get asked that question. So you've got your drugs, medical and surgical items, utilities, etc. And for non-pay, you basically have 4 types of costs. You've got your operational costs, utilities, rent, maintenance, all those sort of contracts. Capital costs, which you can generally bid for. investments in assets like machinery, building technology, supplies, so that's your office supplies, day-to-day, your medical and surgical equipment, and services. There's a few things that are outsourced. Sometimes we bring in consultants, not medical consultants, to actually consult on specific things, possible savings, that sort of thing, and marketing. So additional funding is often received at budget setting for non-pay inflation, which is normally different from your general non-pay and drugs. So that's added into your budget. So you set your budget with your management accountant for pay and non-pay, hopefully adding in everything that should be, taking off things that you've already agreed to, and then you have an agreed budget at the start of the year. As a budget holder, you have to fully engaged with the budget setting process because that is your budget. You need to be able to talk to it. You need to be able to explain why it's overspent, whether there's any costs missing. So make sure that you're fully involved and you understand how the budget is being set. I mean, what should happen is that every single staff member should be recosted. As we know in the NHS, staff work long hours. So on the wards, you've got your long days and your nights covering 11 to 12 hours work. So there are enhancements involved in that. So everybody's got to be costed to include all the enhancements for the 24-hour working. And obviously you've got the AFC pay scales. So people can go up a point in the year over and above the inflationary sort of 3%. So all of that should be captured at the start of the year so that you have the correct budget for the staff that are needed to run the service and to be able to achieve the activity that has been agreed with the ICB. So if you're not involved in it, then I would suggest contacting your management accounts and engage with them.
We've just received some sort of uncorroborated information that a patient that we both care for.
Just make sure we're all
I thought that was relevant to budget holder responsibilities there, but it's not. Okay, so speak to your management accountant and get involved in that. Find out how they're doing it. Offer your help, because the more accurate you get your budget at the start of the year, the better everybody will be, and you won't spend the whole year saying, yeah, but that's because you didn't give me enough budget for X. So get involved right from the beginning. Every single month you should have access to a budget statement that has been completed for the previous month. Hopefully your team at whichever hospital you're at produce that as quickly as possible so that you can look at it, see that you're overspent, and put actions into place to try to pull that back as quickly as possible. You have to, I've spelt manage wrong there, sorry. You have to manage your budget in line with standing financial instructions. That's basically a hierarchy of people who can sign off and agree to spends at different levels within the trust. So make sure everything is done properly is what that means. And use the information from the budget statement so that you can understand why you are over and underspent. Check your staff listing. Like I said, 70% of your costs. So you must understand, why Joe Bloggs has got an additional £3,000 this month. It should be something that you've instigated. So just make sure you're on top of that, and speak to your management accounting team and your planning team just to raise any queries that you have. Get involved with them. The more that the two teams, the clinical and the management accounting finance team, talk to each other, the more finance can help you, and the more finance can understand the pressures that you're going through, and therefore when they're writing their monthly narrative on why a certain directorate is overspent or underspent, they will be able to articulate clearly why that is, and that will then help you. So engagement is very important. And obviously use the information within your budget to help make future decisions and plans, put in business cases for developments that you're aware of, and so that you fully understand your position. As a budget holder, you have to complete staff change forms in a timely manner. This can be done through ESR online. So each trust will be different, but just make sure. Well, one of the key things that payroll dislike is finding out that a member of staff has left the trust, several weeks ago, and in the meantime they paid them a full month's salary. So just make sure that when somebody is leaving, that whatever it is your trust does, you do in a timely manner, because overpaying staff takes up a lot of time trying to claim that money back. And approve goods and services through whichever system that you use, and invoices in a timely manner. This is a budget statement. This is a budget statement at our trust. You can see that the top half is pay, the bottom half is non-pay. In some statements, you then have income at the bottom. This bit here, this section in the middle, is what has happened in the month, and this is year to date. So you can see that the year to date figure is double the in month, because this is at month 2, so it would be 2 lots of budget. And this is your annual budget. So this is obviously 12 lots of your in-month budget, unless there's funny profiling. Things like your gas bill, you might have more heavily weighted over winter, but generally speaking, it's profiled equal 12s across the year. So this particular cost centre, you can see the total annual budget, the non-pay budget, and then you can see the spend against that budget, which you can see here it's overspent. So it's £18 overspent. If only that were the NHS deficit, that would be lovely. But you can see it's got a little red line there to say warning, it's overspent. So that's your pay section, and then this is your non-pay section. And we have whole-time equivalents in the trust. Medics work 40 hours for their one whole-time equivalent, and AFC staff work 37.5 for their one whole-time equivalent. So I've got a couple of little questions here. What is the total annual pay budget? So have a little think. And I'd like to think that you would notice that it is this number here, 1.3 million. So this is your annual budget column. This is 1/12 of your annual budget. So that is your total pay budget. And that would be for 23.82 whole-time equivalent of staff. What is the year-to-date total variance on this cost centre? So this is kind of the figure that you should look at when you get your budget statement each month. In our organisation, it's bottom right. So this is the year-to-date total variance on the cost centre as a whole. So it's pay and non-pay. So you can see it's in brackets, and it doesn't have the red line. So it's 6,500 favourable to the end of month 2. I've then asked a generic, what is the account code for furniture and fittings? So each cost centre, each area has a code, and then account codes or expenditure codes or subjective codes are not unique across the trust. So if you're all on SBS, you will recognise these codes as being generic across the whole NHS. So the furniture and fittings one is 7350. So that is the account code, subjective code, whatever you want to call it, for furniture and fittings. And if you're ordering furniture and fittings in cardiology, it will be the same as ordering it within ED. Now it says here as well, the pay line for nurse band 6 is underspent. So you can see there it's underspent in the month, underspent year to date. and can you explain why? So I'll give you a couple of seconds. So you can see that it's by a similar amount, and then if you look over to the whole time equivalent information, you should be able to see that you've got budget for 5.83, but you've only got 4 in post. 4 whole time equivalent work, 4.91 paid. So when you've got a funny increased whole time equivalent on paid, that just means that those 4 people have worked enhanced hours. So hopefully you can see that the reason why they're underspent is because they've got vacancies of 1.83, which they haven't really covered. You see that band 6, you would kind of expect to see band 6 spend to the same level, but they haven't. Quite often within the wards, they drop a grade if they're trying to cover and reduce the cost. So although the vacancy is band 6, they may well be covering it at bank nurse band 5 to sort of help out. So I hope that helps to sort of explain a budget statement. So those are the answers. And spreadsheets. I like spreadsheets. I know a lot of people don't, but Microsoft Excel has lots of benefits. Pivots, I get quite excited about. VLOOKUPs, that, you know, once you get into it, it saves you a lot of time. There's lots of skills over and above AI that can help you analyze a lot of data. So hopefully cause of death isn't Microsoft Excel, but definitely if you're not sure about it, all of your local IT departments will have beginner courses just to get you going with some of the, you know, pivots. Pivots are great. They would save a lot of time. Even if you got that under your belt, it would help. And like I said, don't be scared. There's, you know, just don't press save when you know it's right, and then you can always undo if it's not. So it's not the end of the world. The importance of budgets. A budget is telling your money where to go instead of wondering where it went, which obviously would help us in our day-to-day life as well, I believe. Take control of your finances by making conscious decisions about how to allocate resources. So be proactive, get involved in budget setting. And the final slide is that. So that concludes my session. I didn't look. Oh, so you've put some questions there. Thank you for engaging in the little quiz. I can see that you're, oh, and you've said, Laura, about are you using 0.91 whole time equivalent working bank or unsocial? So yes, definitely not bank, because that's on a different line, but it is unsocial hours. And I'm sorry, Melanie, that that it was too small. So you put that there's a question from Hugh at Barts. Can you articulate differences between capital and revenue? Yeah, so revenue and capital is kept very separately. It's given out by NHS England. I can't remember the number. It's something like 300, like 400, can't be million, it must be more than that, billion to revenue, and something like 8 billion to capital. It has to be bid for. Basically, capital is anything over and above the value of, I believe, 5,000 to 6,000, or they can be linked assets to that same value, and they go through in a different approval route because it is very different from your revenue funding. I hope that answers your question, Hugh. But yeah, that's the end. Thank you very much for your time. I've given you 6 minutes back, as they say. So if there's any questions or you need to contact me, then please do drop me an email. Thank you.
Thanks, Deborah. Appreciate that. I hope you have a lovely rest of your afternoon as well. Any questions coming through? I think so. I think, AK, are you back on the call now? his name. I'm not sure AK's back, so he's doing the last session for us on business cases at 4 o'clock. So it isn't quite 4 yet. So we'll meet you all back here at 4, just a little 5-minute break or so. Oh, you are here. Amazing.
I'm happy to keep going.
Okay, great. Yeah, over to you.
But yeah, we'll get going because as my previous talks have suggested, I overrun relatively often, and 2, hopefully it means that we can finish a bit early. Fine, so let me just try and get this. Okay, so you should be able to see my slides now. And let's go. Okay, so welcome back. I hope you found the rest of the afternoon interesting and useful. So we're going to be talking about business cases. The caveats I'm going to say is that the process for business cases is different in every organization. What we're going to be talking about is the recommended national process for all public sector business cases. It's called the Better Business Cases, or the 5-case model. And that's what all your internal processes, so all the ones that within your organizations, are essentially based on. If you write your business case according to these principles, then it should fit into the principles for every business case that you need to write, because these are the recommended process as given by the Treasury for writing business cases. There are whole qualifications you can do on business cases, but they are designed for people who deal with multi-million-pound business cases in the public sector, rather than the majority of our business cases, which are tens of hundreds of thousands of pounds, but certainly not multi-million-pound. So going back to what a business case is, there's 2 purposes of a business case. One is essentially a pitch for money, or pitch for resource. So you're trying to say why your idea, why your project should be prioritized over everybody else's. And that's the key thing, is to say that most business cases are sound ideas. Okay, they often are all sound ideas. Occasionally you get ones that are poorly thought through, but most business cases are good, at least the principles behind them. It's all about prioritization. So why should they spend that resource this year on you rather than at some point in the future? And that's what you're trying to do. The second purpose of a business case is much more retrospective. It's much more about why you've come up with the decision that you came up with. So it's a retrospective to kind of look at how you've come up to your solution. And we'll see what that means in a second. So the first step in business case is understanding what processes you need to follow in order to develop your business case. Who do you need to pitch to? So what is your process within your organization? Because that is really quite important. Who do you have to get on side? Who you can have to present to? Is it an internal business case? You need to start thinking about whether you're trying to do it internally. This is where you might need some advice, or whether you're doing it to the ICB, whether you're doing it to a specialised commissioner, whether you should be aiming for educational funds. So this is where you kind of have an initial idea of where you're trying to go, and how many hoops you need to jump through. Is essentially what you're trying to work out. The second question is actually, do you need an actual business case? And what that means is there are 2 other types of options. There's a smaller option, which is an options appraisal. So if you've already got funding, if you've already got the money, or you don't need much investment, and it's primarily about deciding which way you're going to buy, or what you're going to get, or what you're going to do, then you might need an options appraisal. And we'll talk about how to do an option appraisal a bit later on in the talk. And then the other one is a program where you've got multiple business cases that are needed to put forward a whole project. And so there might be a program of business cases that are all kind of interdependent, but they're all looking at slightly different things and for slightly different purposes. So just work out what size you need. So what do you think should be in a business case? And I'm going to ask that question, but I'm not expecting an answer, because it is essentially all the who, what, where, when, why, if, what answers. But what we're going to try and do is put it into a structure. A structure where the first section is the most important section, and that's strategic case. That's the bit where you need the most clinical input, the most operational input. Okay, so we're going to focus a lot on that one. The second component is called the economic case. And that also needs a fair amount of input from those that are writing the business case. Okay. The other three areas are where you need specialist advice. So when you're looking at the commercial case, you need to get procurement or human HR or finance involved, and certainly for the financial case, you'll need to get finance involved. Okay. And then the final thing we'll touch on a little bit is the management case. Okay, so we're going to focus on the top two first, and then we'll talk a little bit about the others. The commercial case is linked into the procurement talk we had earlier. So there are two drivers for writing a business case. Historically, the third driver, or probably in some situations, the most important driver was increasing income. Okay. Nowadays, it's not really as powerful a driver as it used to be. The main driver for business cases is solving a problem. And in order to do that, you have to show that there is a problem. And that's the thing that a lot of people don't demonstrate strongly enough. They don't show how big an issue it is, and then what their proposed solutions are. Okay. The other issue is where you have to it's a less strong, but it's where you improve quality. And you have to show you're not only improving quality, but you have to show how you're reducing the costs. So how is your change in your clinical pathway going to not only improve quality significantly, but also reduce costs? So that's a slightly different angle on the business case, but it's the same. They're the two main drivers for business cases. And it goes back to the value equation that we had right at the beginning of the day. So you need to show that there's an improvement in outcome, experience, or safety that's worth the cost. Okay, and whether it's a revenue or capital cost. And that is the crux of the business case. If you do have a business, a lot of business cases are single steps. Most business cases that we encounter are single step process. If you are involved in a big, significant size business case, particularly ones that will need NHS England approval, then you might be asked to do it in 3 stages. And that's just to make sure that you don't put too much work in it too early on. And the 3 stages are called the strategic outline case, the outline business case, and the full business case. In some organizations, the strategic outline case is basically a 1-page document to make sure you're not doing anything catastrophic. And then the main thing is your outline business case, and you never really do the full business case. So depending on the size of your business case, you may have to do one or all of these steps. Okay. There's the strategic context is where you have and we'll talk to that about that in a second. But the outline case, that is basically where you have your strengths, weaknesses, opportunities, and threats analysis, and you get an idea of the indicative costs. And then every stage you add a bit more. So you have in your outline business case, you have your preferred option and how you're going to manage the delivery of it, and the full business case is where you put everything together. Okay, and it's normally the full business case is normally it's that retrospective document. So once all the I's have been dotted and the T's have been crossed and everything's been done, that's what the full business case is. For most people, it's a much smaller one-step document. So let's start with the strategic case and what it involves. You've got to put it into whatever you're trying to do. You've got to put it into a strategic context. And what that means is, what is your organization's main aims and ambitions for that year? What is their main driving force for that year? What are they trying to achieve in that year? And how does your business case fit that? Because if you can't show that, it may not get off the ground. Okay. If you can show if you can align it really well to what your organization wants to do, then it's more likely to gain traction and be prioritized. Okay. So that's your first paragraph, needs to be that, how it aligns, what it's going to do, what it's going to achieve, how it's going to align to the organization's aims and ambitions. You've got to sell it really early on. What you've got to remember, and this is going to happen, and reference this a few times, is that you, as the people writing the business cases, are the people that know your service inside and out. You're going to know all the quirks, all the things that are going to work, things that are not going to work. You'll know it really well and in detail. The people reading a business case will not know that. So there'll be things that you dismiss, things you assume, things that you options that you may kind of complete disregard because you know it's a non-starter, that then other people who are reading the business case might go, oh, well, why don't you try this, why don't you try this, why don't you try this? And it just slows the whole process down. So address those early on. And we'll talk about when we're going to do that in a bit. The next bit is all about the case for change. And this is the evidence base, or the support that shows why your business case needs to be prioritized. Okay. And the majority of it is related to benchmarking, but other things like CQC reports are quite. I've been muted as well. So other things like benchmarking, CQC, the getting it right first time, model hospital, things like that all add weight. Unfortunately, the NICE and Royal College recommendations have some weight, but they're not as strong as we think the clinicians would like them to be. They are something that needs to happen at some point, but very rarely are they absolutes, because they know that it takes time to implement these things. So, and there are numerous NICE and Royal College recommendations that come out every year. Very few of them are mandated. This is something you should be aiming for at some point in the next X number of years, because we're all starting at different points. So you need to think about it that way. You can try and solve both problems, but you have to assess them not separately, but you have to look at the different options, and that's where the options appraisal comes in, as to what is the benefit of doing them both together rather than in separately. To give you some examples of what you can do, so this is something for the model health system. I keep referencing my model hospital. It's called the model health system. This was, as an anaesthetist, we used to use a gas called desflurane to keep people asleep. It had some particular beneficial traits to it, but it was really bad for the environment. I mean, really bad for the environment. And you can see that our trust, we used a lot more of it than the national average. And so when I was kind of given the task of reducing that, you use this graph and you show that where it's a problem, we are a high user, how can we deal with that, what alternatives do we need? And actually we managed to get money from a sustainability pot, so pot for environmental causes and improvements, to pay for some syringe drivers or some equipment that basically allows us to do gain the same benefits as that gas without having the environmental cost of it. So you can use the data to have that. Another one is, this is for our emergency appendectomy data. So again, this is a bit old, but probably hasn't changed dramatically. You can see that the black line was my trust. We didn't have a very good performance in this particular metric, length of stay of less than 2 days. When you look into it further, you find that it's not actually because our surgeons are particularly bad or we have a particularly high complication rate or anything like that. It's that patients don't get to theatre for 2 days for appendixes because we don't have enough theatre capacity. So you can use that to give weight to your argument that you don't have enough theatre capacity. Okay. So GIRF recommendations are more impactful because they are deemed to be that you're benchmarked against other people. So other people are achieving it. So that's why the GIRF recommendations and benchmarking is seemed to be better. The Royal College guidelines tend to be much more. Everybody's starting at a different level, so it's difficult to assess. Whereas the GIRF is thought to be more achievable. Okay. So the next bit of the strategic case is talking about your current guidance or what current arrangements. So what exactly is your current setup? How are things likely to change in the future? Okay, so what is your demand going to be? So what you don't want is to write a business case now and then have to write another business case within the next year or two for the same thing because you've not been able to anticipate that your demand's going to increase. If you ask for more clinics or more consultants or whatever it is that you're asking for now, and then in 2 years go, oh yeah, we still need more because we didn't anticipate it was going to be a massive increase, unless there's something changes specifically that you couldn't predict. But if it's part of natural natural increase, then you should have anticipated it. So again, you'll get deprioritized. So business needs current and future. Bear with me 1 second. Right, so the other thing is, what is the scope? So what are you trying to do with your money? Is it are you trying to buy? Is it a whole new building? Is it staffing? What is it you're trying to do? You know, what's going to limit you in terms of what kind of ballpark are you looking at, and what your spending objectives is linked into that by saying what you're going to spend it on. Is it staffing? Is it equipment? What kind of stuff do you need? Constraints and dependencies the constraints are normally space is normally the biggest constraint, is where what's going to limit you, what's going to limit your scope or your what you can do, and dependencies are often interlinked business cases. So is there another business case that's dependent on this business case going through, or is there a whole service that's dependent on this business case going through? So that's what dependencies mean. Benefits and risks, obviously benefits speak themselves. Risks are things that might happen, or bad things that might happen. And then there's this word called disbenefits, which is where you've got almost unintended consequences. So benefit is something that will definitely happen, probably. The disbenefit is something bad that is going to happen as a consequence. The most common things are where you've got, so we had example, I had a radiologist talk about a new type of way of doing the breast screening program, where they put a cannula in, inject something in as part of, instead of standard mammograms. It gives more, it's a higher quality outcomes, but it takes longer. So then, unless you mitigate against the fact that it takes longer, you then see less patients. So that's a disbenefit. Or a bad outcome, a negative consequence. Demand and capacity modelling, as you said, when looking at business needs and future, you can look at how things have changed over the last couple of years in terms of your demand, and then look at how that's likely to change. Is anything that's specific that's going to change your demand? Population growth, anything like that might, or a new screening program that will change the demand for the work that you're doing. So look at your demand, and then work out what that actually means in terms of capacity. What capacity will you actually need? Okay, this is taken from an actual business case. So the grey bit was from a historic business case where they worked out that there was an additional income associated with that increase in scans, and so that would offset part of the cost of delivering the new radiologists or radiographers that they wanted in the business case. So that's most of the strategic case, but that's the important bit. Okay, and this is the next important bit, which is where you have your economic case, and this is where you look at all your options. Your options are, when you write your long list, it's basically any potential option or solution, even if it's kind of ridiculous, because then you can write why it's ridiculous, and so people then don't come back to you and go, why don't you do this? And that's happened a lot. Your assessment criteria, you should have an essential and a desirable, essentially, with the essential being your critical success factors. That's the terminology they use in this system. The critical success are your essential criteria. What are the minimum requirements? And the desirables, obviously, the other bits. And then you get down to your short list. So you assess your long list and you get down to a short list. You need to have ideally at least 3 options, including a do nothing or minimum option. And then for each of those options, you do an economic appraisal, which basically is how much benefit you're going to get for each one. And then a cost appraisal is what is a rough cost of each one. So you can look at the benefits. So you'll have, some options may have a lot of benefits but a higher cost. Some may have less benefits but a lower cost. And you can look at just to give an idea of what the more money you spend, the greater benefits you get, type thing. But you want to see what that change is likely to be. So one of the things that people really struggle with, and one of the biggest problems with business cases, when you write a business case with a solution in mind, rather than writing the business case to address a problem. If you write a question with a solution in mind, all the other options are written very woolly. They don't have any impact, and it's very clear what you're looking at. Yeah, the slides will be sent out later on. So the options appraisal has this is an example of how you could do one. There are multiple ways of doing one. This is the one they put in the Green Book, which is the Treasury's guidebook. The scope is, what are you going to do? Okay, so I tend to use the HS2 kind of railway thing. So the issue is insufficient railway capacity across the UK. So the what are you going to do? The minimum is to improve the rail capacity between London and Birmingham. The maximum is to improve between London, Birmingham, Yorkshire, and the northwest. Sorry. And then intermediate is to do London, Birmingham, and one or the other. Okay. With scope, it could be you could have a clinic every week. You could have multiple clinics a week, or a one-stop clinic. There's different ways scope can be described. The how is how you're going to do it. Are you going to refurbish the existing track, build new track, or a mixture of both? Who, in the context of the railways, is very much a local contractor, a national contractor, international contractor, but it's more relevant in healthcare because actually it's is it going to be nurse-led? Is it going to be a nurse and a consultant? Is it going to be a multidisciplinary team with nurses, multiple specialty consultants, and allied healthcare professionals all in a one-stop shop? So who's going to be delivering it? How you can implement it? Is it going to be a pilot? Is it going to be a big bang rollout, or is it going to be a kind of phased rollout? Funding is where's the money coming from? Is it income that's going to come from cost savings? Is it going to be from new income, or is it do we have to get it from somewhere else? Okay, is it internal funding? Okay, so that's where you look at it. And what you do is you write each of those options. You basically highlight in red the things that don't meet your essential criteria, the ones in yellow that meet your essential criteria, and then the green is your chosen options. And they're basically independent variables. So you don't have, there's not that you have to, just the maximum. You can have a combination of maximum, minimums, and intermediates. And in your text, you explain why you've chosen what you've chosen. And that's the best way of getting around it, essentially. Okay, that's how you put your options appraisal together. So this is basically a summary slide of what it is. So the strategic case is it needed? Why do we need to change? The risk benefit, you have to show an improvement in quality. Is it value for money? What options have been considered, and why? Which option has been chosen and why? We talked about the procurement process earlier, and you have to get procurement on board with anything you need to buy. And we also touched on some of the contract issues that you might have that may cause issues. Personnel requirements, you need to make sure you understand what a working time equivalent is. So for consultants, it's wait 1 second. Consultants, it's a 42-week kind of working pattern, and for Agenda for Change staff, which is everybody else, it's a 37.5-hour week. Okay, so when you talk about how you're going to pay for this, it's about, as we said, where's the money coming from? Is there going to be savings? Over what kind of time period is that going to happen? Sorry, the personnel requirements, as I said, it's about 37-hour working week. So to staff an extra clinic all year, you might need 1.2 working time equivalents. To staff a ward 24/7, you might need 3 or 4 working time equivalents, depending on the exact hours you're going to cover. How you're going to pay for this is very much about where the savings are coming from, where the funding is coming from. Is it education funds? Is it a combination of internal funds? Is it from other sources? Particularly if it's a kind of a integrated care type solution. How's it going to be delivered is very much about what we talked about earlier in terms of pilot, phase or big bang rollout. Impact of service delivery is what's going to happen if something goes wrong. You know, if you're doing a construction building, what's going to happen is if the construction is delayed, is that going to have an impact on your service? When you look about how it's going to work realistically, for example, if you're setting up a new clinic, what's happening to the gap in that old clinic? Are you reducing the capacity of the older clinic, or is that capacity going to maybe be maintained and allow more patients to be seen in the other clinic? So, for example, if you were going to do a specialist one-stop multiple sclerosis clinic, where all those patients would usually see in the general neurology clinic, is that capacity in that neurology clinic going to go down to allow the person to do the multiple sclerosis clinic, or will that actually free up extra slots in the general neurology clinics and bring that waiting list down? So what's the impact of service delivery? And then also at the transition, what's your contingency? So for example, when we did some big reconfiguration, and we moved services across our sites. One of them involved renal transplant, moving from one site to another. What we had to do is we had to ask a neighbouring hospital, a transplant centre, to cover our emergency transplants for the 24 hours where we were doing the final move. So what's the impact on the service delivery? So the financial case, think about funding streams, commissioners, how interested are they in the service? Is it recurrent funding? Is it going to be multiple? Is it going to be ongoing funding? So jobs are new posts are ongoing funding, capital builds are non-recurrent. If you made a cost savings type thing, and you're doing investor save type thing, over what kind of time period is that going to happen? What happens if you over on deliver? Does that shift the time period in which you're going to make those cost savings occur? And how much is needed and versus how much is already funded? So that kind of thing needs to be in your financial case. So present your ideas before you submit the business case. Ask for feedback. Get as many people involved as possible to talk about it. Any issues may be blocked if you don't get people to be part of the process. Timing is important, and small business cases near the end of the financial year, new services, especially small business, particularly ones that are capital only, new financial services from the start of the financial year. Think about alternative fundings and combine with the larger business cases if relevant and possible. So that is my whistle-stop tour. that is my whistle stop tour. I just need to answer the doorbell, but if you have any questions, put it in the chat and I'll be back in a second. Hello, sorry. It's actually my it's a car being delivered back to me. That's why I have to be out for a while. Sorry, it's not a big house. Any questions from all that? You can always email me. My emails will be sent out. If you do have any questions, I'm keen to make sure we finish on time today, as I've overrun the last 3 or 4 of these that we've done.
Looks like we're going to get 3 minutes back. So
there are, if you Google them, because I can't quality assure them, I can't tell you what's a good business case or a bad business. Your templates wise, most organizations have templates to write business cases from. And there's certainly those available on the internet. We're trying to create a repository, but very few people want to share their business cases. Once we've kind of had a look at them and just made sure that they are good examples of business cases, we'll put them on the website. Okay. Yeah, we'll try and find some option appraisal templates as well, and send them out. Okay. All right. So feel free to email me, as I said. You'll also get the recording sent out, and if you have any feedback, please let us know. I apologise for the technical issues I had earlier on in the first talk. But great. Thank you very much.
thanks so much, everyone.
Thanks, Lee.
Cheers, AK.
Thanks.
See you soon.
Bye.
Bye.